Hello, welcome to the Northwestern University Perinatal HIV Bootcamp pre-lecture on antenatal care of pregnant people with HIV. My name is Lynn Yee, and I am the medical director of our women's HIV program at Northwestern, as well as the perinatal HIV hotline for Illinois. In this brief lecture, I'm going to talk to you about how to optimize the antenatal care of pregnant people with HIV, and it will be followed by a separate short lecture on intrapartum care. First, some of the basic principles of perinatal transmission. As you can see here, overall perinatal risk of transmission without antiretroviral therapy is about 15 to 25% in individuals who do not infants who do not receive breast milk from the pregnant person, and about 25 to 40% in individuals who receive breast milk from the pregnant person or from the mother with HIV. The numbers here show you that of those who are transmitted HIV in the formula-fed group in the top panel, about 25 to 35% of those occur during pregnancy, and the remainder are during labor and delivery. Whereas among breastfed infants, there is about a 25 to 45% risk of transmission during breastfeeding. Importantly, all of these metrics are from individuals who are not virally suppressed and receiving antiretroviral therapy. So you can see here that our goal of antenatal care of pregnant people with HIV is to mitigate or eliminate these risks. There is a roadmap to the elimination of maternal to child transmission of HIV, which I've outlined here. This starts preconception with optimizing antiretroviral therapy and discussing contraception in order to help pregnant people or people with HIV plan their pregnancies. And I would refer you to Dr. Stephanie Fisher's lecture on postpartum and interconceptional care for more details about this. In the first trimester, it's essential to optimize antiretroviral therapy, review reproductive choice, conduct baseline prenatal and HIV labs, support early pregnancy HIV or early pregnancy symptoms such as nausea and vomiting, and promote adherence. As we move into the second and third trimester, goals include increasing antiretroviral therapy dosing as needed, although this happens less often with current regimens, conducting viral load surveillance and toxicity surveillance, promoting adherence, and then eventually including delivery and postpartum planning. And then in delivery, our roadmap includes planning for route of delivery, providing intrapartum zidovudine, continuing antiretroviral therapy in the intrapartum and postpartum settings, potentially altering labor and delivery practices depending on individual need. We'll talk about this. And then neonatal care. And then finally, you can see the postpartum goals here. Let's discuss some of the core principles of antenatal care. These include optimizing the antiretroviral regimen, such as the timing of medications, the pill burden, side effects, and medication interactions for the pregnant person and their other comorbidities. It also includes monitoring for those comorbidities, such as sexually transmitted infections or chronic illnesses, such as diabetes or hypertension, which can add additional complications to the pregnancy and may be a challenge for patients who are already managing a lifelong chronic disease such as HIV. Some individuals require opportunistic infection prophylaxis. And then a major principle of antenatal care is planning for labor and delivery. This includes discussing the birth plan, infant feeding plans, a high versus low risk neonatal protocol, as well as long-term maternal and infant needs. And then finally, supportive care and attention to psychosocial needs is a major element of antenatal care, which I will touch on throughout. This table reflects the last year's updated guidelines on perinatal HIV from the National Perinatal HIV Guidelines about antepartum screenings and assessments for pregnant people with HIV. What I want to draw your attention to here is the checkboxes that demonstrate when to do each of these, such as assessment of antiretroviral therapy adherence, challenges, and facilitators should happen at each visit, as well as what things should happen at an initial visit only, such as tuberculosis screening, and identification of depression, anxiety, and IPV, which would happen both at entry into prenatal care and as clinically indicated. As you'll see throughout this lecture and others by our team, the perinatal guidelines are an excellent guidebook to management of people with HIV, and I highly recommend reviewing these tables in order to gain familiarity with the antenatal care practices. Let's talk about antiretroviral therapy. All adults need treatment, and we know that ART improves the health of pregnant people. It decreases the risk of both vertical or horizontal transmission of HIV, and pregnant people with HIV should receive treatment as soon as possible, in fact, even before a genotype or resistance panel comes back. I want to underscore the importance of adherence counseling and support. Not only do we need to counsel patients about the critical nature of adherence during pregnancy, but this is a key part of every prenatal visit during pregnancy and then every postpartum visit in order to ensure that we can achieve the goal of an undetectable viral load. The relationship of viral load to perinatal transmission risk has been demonstrated in a number of studies, including this landmark study by Dr. Garcia in the New England Journal, in which they showed that maternal HIV-1 RNA levels over 1,000 were, and over 10,000, sorry, and over 50,000 were associated with an increased risk of perinatal transmission. Since then, it has become well established that HIV viral load is associated with perinatal transmission risk and that this can be mitigated by treatment, as you can see here in the 076 trial. When it comes to antiretroviral treatment, there are a number of medications that can be used in order to create the antiretroviral therapy regimen. Please see Ryan Cates' lecture for further details about this, as well as lectures by our adult infectious disease colleagues. What I will touch on in the next few slides are how these regimens are used in pregnancy and how to identify the preferred and alternative regimens for pregnant people. So antiretroviral therapy in pregnancy and outside of pregnancy typically consists of 3 drug regimens, including 2 NRTIs plus a preferred INSTI or PI. Considerations for pregnancy include both dosing and pregnancy pharmacology, such as whether a dose of a drug may need to be increased in second or third trimester, side effects and risk of toxicity, tolerability in pregnancy, and then prior regimens or known resistance are also important considerations for pregnant people. The perinatal guidelines provide recommendations for preferred or alternative regimens based on factors such as ease of use, lack of teratogenicity, no clinically significant adverse effects, PK data available to guide dosing, acceptable toxicity, and optimal efficacy. And that's how we come up with some of the regimens that you'll see in the next few slides. Over time, there's been substantial evolution of HIV therapy with less toxicity and greater potency, all of which have led to also a higher resistance barrier, which makes current regimens much more effective and tolerable than prior regimens. These are some of the drug options that are available in the current era, with drugs that you can see there at the bottom. There are new ones, including Cabenuva, that have come out, although are not fully used in pregnancy yet. So let's talk about the preferred guidelines for treatments of treatment-naive pregnant people living with HIV. As you can see here, the preferred NRTI backbones are abacavir and 3-TC, TAF, FTC, or TDF and FTC, all of which are now considered preferred guidelines for people living with HIV. In terms of preferred INSTI regimens, dolutegravir is considered the preferred integrase strand transfer inhibitor regimen due to its once daily dosing, its availability as a fixed dose combination, and having sufficient PK data as well as efficacy data about dolutegravir in pregnancy. Raltegravir used to be considered a preferred regimen, but is no longer considered a preferred regimen during pregnancy due to dosing challenges and differences in resistance rates compared to dolutegravir. In terms of PI regimens, darunavir is considered the preferred PI regimen for patients living with HIV who need a protease inhibitor, in contrast to prior prior regimens, which included atazanavir. We now use darunavir boosted with ritonavir. What are some of the antiretroviral medications that are on the horizon? These include things like entry inhibitors like moravirok, new integrase strand transfer inhibitors like elvitegravir and bictegravir. You'll note that bictegravir is in a formulation that we commonly use called Biktarvy, which is likely to become a preferred regimen in the near future, preferred or alternative regimen in the near future. There are also newer 3 and 4 drug single pill combinations, broadly neutralizing HIV antibodies, and then non-oral regimens like the dapivirine ring, which is not available in the US and not likely to be available in the US. And then injectable cabotegravir is not yet used in pregnancy, but I anticipate we'll be seeing pregnant people with this regimen in the near future. This is a little bit on Cabenuva, just to comment on how the medications are changing. I think it's important to note that patients will come to us with unplanned pregnancies on the cabotegravir rilpivirine regimen, and we'll need to be able to understand how to transition them to an oral regimen appropriately for pregnancy. Let's transition away from drugs now and talk about some other key counseling aspects of antenatal care. First, it's important at the first visit and subsequent visits to talk about the risks and benefits of all possible ART regimens that a patient is on. This may include switching a patient from a non-pregnancy preferred regimen to a pre-pregnancy preferred regimen if after counseling about this, she desires to do so. Or it may include counseling about staying on a stable pre-pregnancy regimen if it is working well for the individual and she desires to keep that stability. As I mentioned before, it is important to emphasize ART adherence at the first visit and every subsequent visit. And then we also need to discuss with patients the increased frequency of viral load monitoring compared to a pre-pregnancy state, as well as the phases of care to prevent perinatal transmission. And by this, I mean discussing with patients that there are antepartum measures, intrapartum measures, and postpartum and neonatal measures taken to prevent perinatal HIV transmission. We also want to emphasize the role of the multidisciplinary care team and help our patients understand that there are multiple team members who are invested in supporting them with their pregnancy with HIV. And then I want to also make the important point that we cannot forget routine prenatal care. And this includes counseling about things like genetics, nutrition, weight gain, vaccinations, safety, and other measures. It is unfortunately all too common for people living with HIV to feel as if all counseling is focused on HIV, but we have to remember that the basics of prenatal care are key to whole person care as well. And then finally, the last couple things that are key counseling aspects include mode of delivery and infant feeding planning, which you'll hear about in a little bit, and then family planning and reproductive choice. In terms of labs and surveillance, I won't read this list to you, but you can see here that these are some of the labs that we recommend in the first visit. These include all prenatal labs, as well as some labs that are unique to people living with HIV, such as baseline CMV and toxo, T-cell monitoring panel, viral load, a genotype if viremic, quantiferon, GXPD, and HLA. And then with subsequent surveillance, current perinatal guidelines recommend viral load monitoring about every 2 to 4 weeks if an individual is high risk, meaning someone who has a late presentation to care, has had adherence challenges or has AIDS, or is not yet virally suppressed. This may include somebody who started medications during pregnancy and has not yet achieved an undetectable viral load, and you are watching it come down. On the other hand, if somebody is suppressed and known to be adherent to their antiretroviral therapy regimen, the viral load can be spaced out to every 8 to 12 weeks. It is recommended to have a final viral load within 4 weeks of anticipated delivery, which is typically around 36 to 37 weeks. In terms of toxicity labs, including a comprehensive blood count and chemistry, it should be noted that toxicity is much less common now than it used to be with older regimens. Nonetheless, though, we do surveillance at baseline and then at the first visit after medication initiation, and then approximately every 8 weeks, unless an individual has signs or symptoms of toxicity or you're monitoring for changes in a specific lab, such as bilirubin. It is possible that if someone is on opportunistic infection prophylaxis with side effects, that we may monitor more often. For further surveillance, we recommend toxoplasma and CMV, IgG, and IgM only be conducted monthly if the CD4 count is low. And then in terms of the CD4 count, the latest perinatal HIV guideline recommend that another CD4 count is not needed again in pregnancy if the CD4 count is above 300, the viral load is suppressed, and the individual is on antiretroviral therapy for 2 or more years with consistent adherence. If these factors are not true, it would be recommended that the CD4 count be obtained every 3 months, obviously in joint consultation with the adult ID colleagues. Sexually transmitted infection surveillance would happen repeated with the 3rd trimester labs if risk factors warrant, and then all vaccines need to be given to the pregnant person with HIV, with new on the horizon, probably the RSV vaccine. In terms of invasive diagnostic testing, I think it's important to note that most evidence for invasive diagnostic testing predates the era of viral load monitoring. We recommend avoiding CVS due to direct contact with maternal and fetal blood, but an amniocentesis may be performed after thorough patient-centered counseling about the risks, rationale, benefits, and alternatives. Also, after the initiation of an effective antiretroviral regimen and ideally achievement of an undetectable viral load. If an amniocentesis is indicated in a person without an undetectable viral load, it's recommended that they undergo in-depth counseling with a maternal fetal medicine expert. And the perinatal guidelines note that data are inadequate to guide decision-making about other invasive procedures or invasive diagnostic or therapeutic procedures like PUBs or fetal therapy. And then I want to comment on the importance of team-based antenatal care. A multidisciplinary team is required in order to really provide full comprehensive care to the person living with HIV. This includes not only the obstetric clinicians, but also the person's primary care clinicians, HIV specialty care providers, mental health and substance use disorder treatment services if needed, intimate partner violence support services if needed, and then for almost all patients, connection to public assistance programs or other social services programs. I will end there. I want to thank everybody for their attention and guide you to look at the perinatal HIV guidelines should you desire more in-depth information about any of these concepts. Thank you.